The AHA is pleased to present Leadership Rounds, short conversations on a range of key issues that AHA Board Chair Dr. Melinda Estes will have with hospital and health system leaders from across the country. In the premiere episode of the series, Dr. Estes, President and CEO of St. Luke's Health System in Kansas City, Missouri, is joined by Dr. Marc Boom, President and CEO of Houston Methodist, to discuss how the health system is navigating the COVID-19 crisis in Texas.
Good afternoon, and thank you all for joining me today for our first leadership rounds. Launching this new series today, I'm looking forward to having conversations with healthcare experts from around the country on pressing issues we're all facing. We'll keep these discussions brief, about 15 minutes, because I know all too well just how busy your days are. With COVID-19 challenging our hospitals and health systems in new ways every day, we're all working to provide the healthcare possible for our patients, and we're doing it all in different and innovative ways. The ability to listen and learn from others is an essential strategy as we face our challenges, and that's exactly the goal of these leadership rounds. I'm delighted to welcome our first guest this leadership round series, Dr. Marc Boom, President and CEO of Houston Methodist, who joins me today to discuss how his health system is navigating the COVID-19 crisis in Texas. Houston Methodist is a 1,000-bed plus hospital network affiliated with a number of academic institutions that support its teaching and research initiative, including Weill Cornell Medical College, New York Presbyterian Hospital, Baylor College of Medicine, the University of Houston, Texas A&M, and UT Health Science Center. Dr. Boom is a board-certified internist and geriatrician and still maintains a part-time clinical practice. He's assistant professor of medicine at Weill Cornell Medicine and an adjunct professor of management policy and community health at the University of Texas School of Public Health. Marc, welcome, and thank you for joining me.
Thank you. It's good to be here.
Methodist began preparing for COVID back in early March, and while you've certainly been caring for COVID patients since that time, Houston is now seeing its largest surges. Could you share with us some of the early learnings and practices with your teams have been able to quickly redeploy now to respond to this large influx of patients?
Sure. And to put that into perspective, right now we have patients with diagnosed COVID, about 725 or so across an 8-hospital network that has about 2,400 beds in total. We have another 100 or so, PUIs and workup. In the first curve, our total, including PUIs and positives, was about 275. That was on April 10th. So very dramatic difference this time, and leveling off a little bit this last week, but we're still concerned about testing numbers post 4th of July in town and that going back up. We've learned a lot, like so many institutions have. Our clinicians really have done a lot of great things. We were the first institution in the country to use convalescent plasma, and we've now used that, and it's going to push 400 patients pretty soon. Optimistic about the data we're seeing and really trying to move to working with the FDA to use that earlier to see whether it will prevent progression of disease. We were involved in the remdesivir trials and now are using that as actively as we possibly can, given the shortages, but we get large allocations. We just got a very large allocation yesterday, so many patients with that. Proning and delaying intubation, many other things along those lines clinically, but you can't underestimate the art side of medicine either, and the experience that our clinicians have gained over now. It's going to push 5 months since we were caring for our first patient in about 2 weeks, because our first couple that were travel related were right at the beginning of March. And I think that art side of medicine matters too, experience matters, and I'm really proud of what the team's been able to accomplish. We learned a lot about, many other things, from virtual ICU to use of iPads to communicate, to obviously outpatient virtual medicine, to management side virtual officing and meeting. Many things have been quite useful during this time as well.
Well, while COVID has certainly presented us with a number of difficult and unanticipated challenges, as you alluded to, it's afforded us really some interesting new opportunities to rethink the way we deliver care. Can you talk some more about the new strategies and innovations that you've employed, not only to fight the virus, but also to just help improve care in general?
Sure. And, it's there's that old saying of, luck favors the prepared mind or something along those lines. And I feel like that has happened quite a bit. For several years now, we've made digital innovation a major focal point of what we're doing. So when we needed to pivot into so much virtual outpatient care, particularly with our specialists who were not doing much to begin with, we were able to ramp that up dramatically. There's no question in my mind that we will continue that at a pretty high level going forward. Obviously, lots of details to sort out in terms of reimbursement, logistics, et cetera. On the primary care side, we were already doing a lot of virtual urgent care, and now I see significant strategies of continuing that going forward. When we think about our duty to bring the cost of healthcare down and to serve more people across the country, I think digital medicine, virtual care, some of the virtual officing and other things that will happen in the administrative side are real viable cost containment strategies over the long term as we pull some capital base out of our institutions. I tell our primary care physicians, if you're in a 5-person office, we're going to figure out eventually how we get you to a 10-person office, because part of what you're going to do is virtual care. Part of what you're going to do is in-person care. And if you think about the capital base and the efficiency associated with that, that will be very significant. That's one example. Another key example was virtual ICU for us. We were just opening up virtual ICU. It couldn't have been a better time other than if it had happened a month or two prior. And it's been a very powerful tool. I have no doubt that is going to stay with us and be a very great tool for caring for patients. In COVID, one of the great things it enabled us to do is obviously extend our reach and be able to care for large volumes of patients. But also we had some providers who, are highly skilled, but for various health reasons, age reasons, and others, were not people who should have been on the front lines. And we were able to put them in a virtual setting and basically preserve their ability to help patients with COVID and the other patients we're caring for.
I couldn't agree with you more. It feels to me like anything that can be digital in the future should be digital. I think it's going to be a very powerful learning from this crisis.
No question.
The reality is that, for the foreseeable future, we're going to need to learn how to live and function in a bifurcated world. One where we continue to provide medical care, and we hope we don't see the deferral of care that we saw in the March-April timeframe, but also learning how to survive and coexist with the virus. What practices or protocols are you planning to hardwire into the culture and operations, and how do you see those changes affecting the patient experience?
Yeah, that's a great question. Hand hygiene was always a huge priority of ours, and we did pretty well when we did Secret Shopper and other things. But at the end of the day, we knew we're still not doing well enough. I'm certainly hopeful that many infection prevention kinds of practices that we all have really hardwired in stick this time for so many institutions. So I have a theory that we are all together going to drive hospital-acquired infections down dramatically as a result of this. And I think that may be one of the key learnings. On the clinical side, when I talk to our clinicians, there are some things, for example, proning that has been used so actively in these patients that they're taking a look back and saying, some of those really sick flu patients we have, some of those patients who end up on ECMO with flu, we may need to think about some of these strategies there. So I think there's going to be some clinical learnings that move out as well going forward. And I'm very optimistic about that. I talk about with our team what I call the sacred and what I talk about is that our sacred responsibility as providers, as physicians, as nurses, as clinicians, as hospital employees, is to fulfill the care of COVID patients, and that's the sacred and to fulfill the care of the patients without COVID who still need our care. All of those patients we know during wave one who many times were deferred with harm, many times were deferred and suffered pain or mental anguish. We know that emergency rooms were avoided and people died as a result. We've all seen that in our data. We can't let that happen again. And we need to make sure we manage to care for both populations of patients. And the third part of the sacred and is caring for each other. We have 26,000 employees, about 900 employed physicians, but another 7,000 affiliated physicians, their office staffs. Those individuals count on us as an institution for their livelihood, count on us as a place to help care for their patients. And so we need to care for those individuals, from PPE to mental health and support, to financial support. And we've been able, thankfully, at Houston Methodist to get through this without a furlough, without a layoff, without a pay cut. And that's, it took some intestinal fortitude going through April, but very dedicated to that because, to ultimately emerge from this stronger, we need those wonderful people at the front lines doing the care that they provide.
Texans are clearly well aware of the resurgence of COVID throughout the state and their increased recommendations to stay home and executive orders to cancel elective procedures. How are you balancing all of the messages and keeping patients safe, but giving them the confidence to come to the hospital when they need it and not delay care again?
Yeah, I'm going to answer two parts to that question. So the messaging to patients has been very, very intentional. Obviously, a lot of that happens frontline by our clinicians and through Epic and through other communication channels with existing patients to really educate them, reassure them. We have, from a very purposeful marketing standpoint, now I'm talking back in the May timeframe when we were opening back up, but we were not having a massive surge, really getting the messaging out. How safe hospitals are. And even today, in the midst of this very massive surge, I am absolutely confident that our hospitals are one of the safest places in town. You walk around, everybody is following protocol. We do surveillance of our admissions. We do surveillance of our employees. And we know that we do not have hospital-acquired COVID happening. And in fact, I think much safer than many other places people go. So a lot of messaging around that. But the complexity of messaging is probably the biggest challenge I think that we face. So for some of the people listening who may not be in a community yet where you've seen a second surge, I hope you never are. But if you are going to, and I think it's likely many will, probably the messaging side has been far and away the most difficult. So the public heard the first time around, that this is all about protecting the elderly and protecting the vulnerable. So when we opened back up, the people who weren't elderly and didn't consider themselves vulnerable ultimately acted as if they were invulnerable, and that has come back to really burn us. And trying to re-educate around that and have people understand that, frankly, we see critically ill 20-year-olds and we see critically ill postpartum patients and others, and understanding that if you have enough numbers of people under 50, you will have significant numbers of people very ill and dying in that group. So pivoting that messaging has been a real challenge. And frankly, in the first surge, we felt it. I know everybody else felt it. There was this unity that happened across the country. We were facing this common enemy. And what's happened on this second surge is our country is anything but unified. And so, we as leaders in hospitals and healthcare systems, physicians, other clinicians, we have to lead the way in demanding, frankly, unity from our elected officials, from the press, from our general public, so that they are doing the right things. I mean, the fact that we are all playing whack-a-mole on, either crazy ideas that are showing up on the internet, or certainly in dealing with masking as something that we know is effective and is such a simple sacrifice for everybody, it's very frustrating for the clinicians and a very heavy lift for all of us. So for those who haven't quite gotten to a second wave, I mean, if I had more to do back then, we would have been pounding even harder. It felt like we were pounding the education, but pounding even harder the educational front. So give you a couple examples. 4th of July came around and we were looking at that with a little bit of terror, frankly, because we had such high numbers, recognized the ability, like with Memorial Day, to recharge, in effect, reload the guns, in effect. And so we literally wrapped the paper with advertisement for 4 days of stay home, stay safe, all of the messaging. Spent literally hundreds of thousands of dollars to get those messages across our community. Continue to do that, and it's really going to take a very concerted effort from all of us to shift some of this message back and to bring a more unified messaging so that we can move together as a country.
Yeah, thank you. I mean, masks are important, and we can't emphasize it enough. Finally, let me just talk a little bit about, I know that you have experienced, and you just alluded to, the immense pride in the health system throughout the crisis. But as physician leaders, we know that our teams are made up of people who are in real danger of getting tired and overwhelmed. You mentioned taking care of each other. What strategies are you doing to support these caregivers?
Yeah, that's a wonderful question. We have, from day one, reminded everybody, very early on with video messages, with many other messages, that we are running a marathon. And so from day one, we all need to think about, how we care for each other, how we care for ourselves, and keep ourselves and our stamina up. We didn't quite realize maybe it was going to be, that the first hill we went over was a foothill, and now we're climbing the mountain a couple months later. And so people are tired. It's, we're going to push 5 months by the end of this month of people going at this. And there's no question, especially the front lines are tired. They're resilient. They're amazing individuals. I hear consistently how much they were called to do this, and this is exactly what we train for. I mean, those are common things I hear. I certainly feel that way, but we're all human, and it's tough. So many, tangible and intangible things. One is just transparency and communication. So everybody knows where things stand. When there's a problem, we talk about the problems. When there's solutions, we talk about the solutions. And when we can rally together and see hope, we talk about the hope with cautious optimism. And we do that regularly. And I think people feel valued and people feel part of the solution. We've acknowledged from day one that, the science is messy in real time. And so we will see lots of differing things happen over time, and have educated around that. We're a faith-based institution. We have what we call our I Care values: integrity, compassion, accountability, respect, and excellence. So we've messaged a ton around that. We've put a lot of support in place with a very robust chaplaincy program that we have here, with a lot of employee assistance programs. And we've reached out to the community. And I will tell you, in wave one, this was a lot easier. We had, lots of gifts and meals and everything flowing in. And I've pushed with the community to say, hey guys, we've gotten a little complacent, and a lot of that love and support that our people were feeling is a little less now. Everybody's tired in the community, and everybody's gotten back to work and other things. And so we've amped back up, the meals that come in, the cards that come in, the social media posts that come in, the athletes that say thank you. All of those little things mean a lot. But I will tell you, one challenge that we are clearly facing is, I have employees come in, they're taking care of sick people, they're dealing with loss many times, and then they go out and they see how people in the community are acting. And there's a big disconnect there, and it's really tough sometimes for all of us. I will say, me personally, to see that and the frustration at our community not coming together to do the things it needs to do. And so I tell the general community, if you want to love your hospital workers, your frontline clinicians, the first and foremost thing is do what we need to do together to do the right things in the community and bring this under control.
Well said. And on behalf of the AHA and the entire field, thank you so much for joining me today. I know you're a busy person right now, and it makes your insight much more essential for all of us. And I want to thank everybody for joining today. I hope you'll be back for our next leadership rounds with Dr. David Pearlstein, President and CEO of St. Barnabas Hospital in Bronx, New York. Thank you. Until next time, stay safe and be well.
Thank you.